set the recording. Excellent. Thank you, everyone, and welcome. Thank you very much for joining us this evening. My name is Megan Foster. I am a cisgender female, and my pronouns are she and her. I work with Sport Manitoba as the lead for the Safe Sport portfolio, and I'm connecting to you virtually from Treaty 2 territory and the traditional lands of the Métis, Anishinaabe, and the Oké-Tishikovan people. I myself love living and working out of Brandon, and I'm continually working on understanding further about the privilege I have and what my family and my kids will have based on all that I have as well. And I invite you to learn more about the traditional lands where you and your family now call home. And if you haven't done this before, please visit native-land.ca and you can search for your address or town. And further to that, I encourage you to become more familiar with the calls for truth and reconciliation that are related to you directly and your areas of interest. And tonight we are all joined together through the theme of health and sport. And those calls are numbers 15 to 24 and numbers 87 to 91. So you can certainly do more learning as many of us are. And we're lucky enough to have the National Center for Truth and Reconciliation right here in Manitoba at the U of M campus. So I encourage you to visit their website and visit them in person if you have that opportunity to safely do that. And in the meantime, I'm going to share both of those resources in the chat for you. Earlier this week, the Honorable Kathy Cox, our Minister of Sport, Culture and Heritage, proclaimed this as Concussion Awareness Week here in Manitoba. And the Concussion Awareness Week is a federally recognized event that's happening for the first time this year. Concussion Awareness Week came about after an athlete named Rowan Stringer died from second impact syndrome, and her parents, Gordon and Kathleen, became tireless advocates for concussion awareness and education and anything that that can be done for prevention of something like this. Rowan's Law Day in Ontario became the catalyst for this year's first Concussion Awareness Week. We do a really great job here, and Canada is the only country in the world with national guidelines and sport-specific protocols. And here in Manitoba, we are very proud that many of our provincial sport organizations and sport partners have developed their own protocols and posted those publicly on their websites. So if you aren't familiar with your sport's protocol, I strongly encourage you to look into that. If your sport doesn't have a protocol, reach out to them and ask where it is, what are the steps, what are the processes, and where can you find more information. If they aren't sure how to do that, you can let them know that you saw this webinar and that they can reach out to me at Sport Manitoba, and I'm happy to help them work through that together. So Manitoba's Concussion Working Group really truly is leading the way here in Canada in this work, and our plans for Concussion Awareness Week reflect that. This workshop is just one of those events, and without further delay, I would like to get started in this workshop. So I'm going to invite Carter Wall to begin our session tonight. Carter, take it away.
Hi, everybody. I am Carter Wall. I am a freshly graduated high school student and a retired hockey player. I have been playing hockey since age 5'6", all the way up to AA midget. Throughout this process, I've suffered a numerous amount of concussions in my career, and a lot of those to this day impact me. In my last 2 years of playing hockey was when I suffered my most concussions, most recently and so close together. I'd suffered 5 concussions in the past 2 years, 3 during my first season of AA midget and 2 during my last. While I was in the tournament down in Minneapolis, I unfortunately suffered my last concussion that put me out of the game. Before that, I had an exhibition game, which I had suffered a minor concussion, which had led me to be more cautious of my health. During this process, a lot of repercussions have come up. I have dealt with depression, anxiety. I deal with migraines on a daily basis. I deal with blurred vision from looking at screens too long. I have a lot of numerous things that still follow me to this day, and I think it's very important for concussion awareness to be spread, for this meeting to happen for everybody. I'm trying to put my focus more towards coaching younger athletes to see that that there is big risks to concussions if you let it go on too long, or if you need to hide the symptoms because you need to keep playing. I know well enough that I would tell my players that if you do have concussion or think that a concussion is possible, you should talk to your coaches. And even if it does mean sitting out for a couple of shifts to see how you're feeling, or it means sitting out the rest of the game and going to a doctor to get properly diagnosed, I think it's very important that concussions are now properly diagnosed. My brother, quite a few years ago, had dealt with this, and he still has symptoms to this day. That was almost 5 years ago now. He had suffered a really bad hit from rugby and was never the same after that, and is finally starting to pull around now. My first couple concussions had all been minor ones until I wasn't wearing a helmet one day on a skating rink and hit my head pretty hard. After that, I went home throwing up and realized what concussions really were, or at least I thought. Until my brother had his, and I went to the hospital with him and realized that there's a lot more to this than I understand. And with all the people here and all these moderators here today have helped me learn that there's a lot more to concussions, scientifically, neurologically, and that there's different ways to help. And one of them is to spread awareness. As a hockey player, you do need to know that as an athlete, as a hockey player, as a coach, as somebody who's trying to get into sports for professional level or just for fun, that helping other players, your teammates, your coaches is a big thing. If you feel like somebody had been hit to the head pretty bad, that could be an elbow, that could be going into the boards wrong, that could be going up for a basket and somebody bumps you and you fall. I have seen it all. I've had numerous friends who have had concussions, and there are a lot of symptoms that affect them to this day. It is about knowing your own body and knowing when, I don't want to say to give up because that's not it. It's when to help yourself. If you do think that this is possible, talk to your coaches, talk to your parents. You do need that bond with your parents to be able to be honest with them and say that, hey, I think that I do have this concussion. I've been having migraines for the past couple of days. My effectiveness to light, and just get it properly diagnosed. There are tons of athletes and other people who hide these symptoms, and then it gets worse until you finally just realize that, or everybody around you starts to realize that, hey, this person's a little bit off. During my playing career, I love playing hockey. It's all part of my family. We watch the playoffs every year together. Hockey was everything, but I know that I can push my focus now towards coaching, and that I can make myself a better benefit and to push concussion awareness for everybody. So I just want to say thank you.
Thank you very much, Carter. And we hope, Carter, that you're able to stay for the session if you'd like. So if there are questions that you've got for Carter, you're welcome to put them in the chat now, or we can, we do have time for some questions after. So we're happy to do that a little bit later. So we're going to move into a bit of a presentation now, and we've got two members of the allied medical field here with us. And we've got Dr. Ellis, who is the medical director of the Pan Am Concussion Program, and he holds clinical appointments in the Department of Surgery and Pediatrics. And he's also the co-director of Canada North Concussion Network, and has a scientist appointment in the Children's Hospital Research Institute of Manitoba. His main research interests include the clinical epidemiology and management of pediatric sports-related concussion, as well as the advancement of novel neuroimaging and exercise science assessment tools in concussion. And we've also got Jeff Billeck with us, and Jeff is the chair of the Sport Medicine and Science Council here in Manitoba, and he's also the head athletic therapist for the University of Winnipeg Westman Athletics, and he manages the athletic therapy clinic in the Duckworth Center. Jeff certified as an athletic therapist in 1999, and prior to that graduated from Manitoba, University of Manitoba with a bachelor's degree in physical education, and most recently completed his master's degree in rehabilitation in 2016. So I am going to now hand it over to Jeff to start us off, and we will learn a lot more about concussion and what that means from Jeff's perspective. So Jeff, over to you.
Okay, thanks, Megan. Yeah, hopefully I can, sort of shed some light on the sort of on-court, sideline, and referral process of concussion. And we did a similar presentation on Monday. We're using basically the same slideshow, just gearing it a little differently. Our talk was mainly with our medical professionals on Monday. And the way we want to go about that is just presenting a bit of a case, and we'll try and relate back to this case as both myself and Dr. Ellis sort of talk our way through it. So tonight we have a 16-year-old female basketball player that was elbowed by an opponent in the face and fell to the floor and a bit slow to get up. So at the end of the play, she had an assessment on the court by the team athletic therapist and didn't experience any loss of consciousness or evidence of any seizures, but did have headache, dizziness, nausea, neck stiffness, and some blurred vision in her right eye. So we removed the athlete from the court, took her to the training room. And again, we're going to go through this process in more detail. I'm just giving a quick overview, and we'll kind of backtrack in a minute or two here. So after 15 minutes of observation, sort of like the concussion assessment tool suggests, that they underwent that test after this rest period. They didn't have any major red flag symptoms: numbness, weakness in extremities, double vision, neck pain, worsening headache, but just the persistent blurred vision in the right eye with some swelling around that eye. And then based on the results of the SCAT-5, they were recommended to stay out of the game and get assessed medically. So their parents were notified, and they were given a post-injury education sheet that outlined some of the main goals after an injury like this happens. So being able to understand their signs and symptoms, what a gradual return looks like, potential consequences of a early return, and warning signs that would prompt sort of immediate or urgent medical care. And then because of the concern of the concussion, as well as, we're not sure of the extent of the facial injury, they were advised to go to the nearest emergency department. Okay, once they were seen at the hospital, they continued to have the same symptoms, and with the concern of the facial injury, underwent a CT scan, and no evidence of any major fracture or intracranial abnormality. So no major or no severe brain injury signs or symptoms from that CT scan were found. And then the patient was discharged home for a follow-up to see Dr. Ellis the following day. Okay, so the part I want to talk sort of through the recognition of the injury, removing the person from the court, assessing them on the sidelines, and making sure they're referred properly. But before we do that, I think in any community sport and really any level of sport, the preseason education is extremely important in preventing sort of any confusion or even conflict during the season when these injuries happen. We need to know, and everyone on the team needs to know, coaches, parents, athletes, managers, anyone involved need to know what to expect if the injury happens. That if there's a mechanism of concussion and signs or symptoms of concussion, the person has to be removed. That's one of the sort of many education points. And the Sport Medicine Council and a number of other groups have developed sort of preseason education tools and seminars that can be delivered to groups to help with this. And then we'll talk a little bit about the concussion recognition tool that sort of simplifies that on-court sideline assessment in recognizing and removing someone from sport. So again, the basics of any evaluation of any head injury, head or neck injury, would be ensuring that if there was a significant impact like we had in this person, so if we go back to our case study, there was a significant elbow, enough to cause swelling and blurred vision in their right eye. They have 4 different signs and symptoms of concussion, so this person must be removed. But first, before we're moving this person off the floor, we want to make sure there's none of these sort of 911 or red flag symptoms, that we don't need to call EMS for this person. So I can speak for myself, if I go on the floor as an athletic therapist to attend to an injury and they're laying on the floor, my first thing is to make sure I've been called on the floor first, that I've been allowed to come out. And then I'm probably going to place my hand on this person's head and just remind them not to move for a minute. I just have to ask them some basic questions. I want to understand where their pain is, what their symptoms are, and then understand if they have any of these red flag symptoms. And the recognition tool really simplifies this. It's a one-page document that has all of these listed. But if they do have any of these 9 symptoms, we may need more, or we will need more urgent care, and we'll be sending our call person to call an ambulance. So the neck pain or tenderness, obviously, we have to rule out a spinal injury with any head injury. And we can do that with questioning the person, also making sure there's no weakness, numbness, tingling in their arms or legs, no severe or increasing headache. If their headache's increasing rapidly and really bad, maybe causing them to vomit, these are major signs and symptoms that we need to deal with immediately and get them to the hospital. So, and here's the recognition tool that I'm talking about. All of those signs are listed in the red box under step 1. So we're making sure within step 1 that we're recognizing any of these major symptoms and activating EMS if needed. If we've gone through that list, there's no neck pain, they're just complaining of their headache, a little bit dizzy, then we can start to go through more of the observable signs. What do we see with this person? How willing are they to move? Are they really dizzy, nauseous? Do they feel like they're going to be sick? Do they feel like the room's spinning? Are we going to be able to help this person to their feet? If we are, we do that gradually. Maybe they get up on one knee slowly. Maybe they turn onto all fours first, then up on one knee. Always asking if anything's changing with them, they need to let us know. And we're doing that process slowly to get them from the floor up to their feet and to the bench. And then there's different ways. Maybe we need 2 athletes, if it's a really tall athlete, to help them over to the bench, sort of use a 2-man crutch, always keeping someone close to them in case they do lose their balance, obviously. And then we want to know about their symptoms. What exactly are they feeling? How oriented are they? Do they know where they are? Can they read the scoreboard for us? Do they know approximately what time it is? Things that you know the answers to, and that the athlete should have a good idea of. And then obviously the athlete shouldn't be left alone. And then we'll give them some home instructions once we get through the sideline part of things. But this is a one-page tool that I believe we now have with Sport Med Council sort of put onto clipboards that will be available for coaches and managers to have right on the sideline with them. So just to kind of review that on-court process, we got to make sure it's safe for us to go on the court. And this is very different with different sports. But in our basketball, it's a pretty controlled environment. The referee will blow the whistle. They can call us on. The play's stopped, and we can deal with the injury safely. We do want to determine the chief complaint, but we also want to make sure they don't have any of those red flags. So like I said, maybe we're advising them not to move at first. We need to check a few things out. We need to know if they have neck pain. We understand your head's hurting. Is there anything else that hurts? Maybe palpating that neck just to see if there's any soreness and make sure we're not missing anything. Calming the athlete would be extremely important. This is going to be an anxious situation. They might be slightly disoriented. Can you take a big, deep breath for me? Just take a minute. Can you read the scoreboard? What does it say, on the advertising sign, whatever it might be. Just kind of refocus them a little bit, try and get them calmed down. And then it'll give you a picture as well as you ask the orientation questions of their level of consciousness. Are they kind of coming in and out of consciousness? Can they answer your questions clearly? How oriented are they? to the questions you're asking, and how clearly can they give you their symptoms. If we're assessing younger children, this can be a challenge. They may not understand their symptoms clearly. So we want to be really clear on what we need to know. And then, like I said, determining the safest method for removal from the court. How do we get them to the sideline safely, making sure they're supported? So once we get them to the sideline, then we want to sort of reassess things. We'll give them 10 to 15 minutes rest. We'll monitor them that whole time. They're never alone during this process. Even if they go to a therapy room off to the side or a change room, someone has to be with them to monitor for those red flag symptoms, especially if if they're worsening, if they're vomiting, the headache is increasing, really any of those 9 symptoms on the list on that recognition tool. We need to be mindful of watching for those things while we're waiting to reassess. If there's no concern for any of these major injuries, obviously a concussion still suspected in our case, and they need to be removed from play. And at this point, maybe parents have come down and there's some, I'll say, negotiation on this. With concussions, there really can't be a negotiation back and forth. If there's a mechanism and signs or symptoms of a concussion, then the person has to sit out. This is what the guidelines say in every province in Canada and with every sport governing body, especially within Sport Manitoba. So, and it's actually law in Ontario now, following Rowan's law. So if you have the luxury of having a therapist on the sidelines or a medical professional, maybe it's a sport physiotherapist, maybe it's a sport medicine physician or a physician on the sidelines, they can go through the SCAT with them. And the SCAT card will give them some details that are helpful as you refer the person on. The gray areas of concussion are that there's 2 parts, I guess. Symptoms can be delayed, or the athletes can hide the symptoms somewhat. They're competitive, they want to stay in the game. And I always say we want athletes that want to be on the field, but we have to be honest when it comes to head injury symptoms. So we want them telling us if they're not feeling good, or at the very least having teammates advise us that, hey, so-and-so isn't feeling so good, maybe you should check them out. And if we are using the SCAT tool, just, so everyone's aware, it is not the only tool that we would use to make a return to play decision. There's many other aspects to concussion assessment as far as making sure someone has recovered from a concussion to return. So it's not a tool that we would use for that situation alone. Okay, and obviously, like we've said already, anyone with a suspected concussion has to be taken out of the game and referred for medical assessment. Okay, and this is just the purpose for any medical practitioners that are on the call tonight. We can use some of this info as documentation. We can use it as a referral document to other medical professionals. It gives important home information for the injured person. I can't remember exactly, it's either page 5 or 6. There's an important home information section to the SCAT-5 that can go home with the person. And they understand what those red flag symptoms are. They understand what they're watching for. And their caregiver that's looking after them can watch for those. Okay. In most settings, you're not going to have an on-site therapist. And this is where that preseason education really comes in handy. Like our cartoon here, this teammate recognizes that their teammate's having a problem, and they're recommending that they, maybe they need to get checked out and make sure they're okay. So before they do anything else. So if we can get athletes to kind of help each other in this manner, instead of some of the stories I've heard in the past of athletes helping others off the field when they're injured so they can stay in the game. This is an important thing. We really need to be looking out for each other in all aspects of sport, whether it's athletes, coaches, therapists, and kind of put the competitive part aside when we start talking about concussion. Okay. So I know that's kind of a quick run through of what we would kind of do on court, on the sideline, and then as far as referral. So this is kind of an outline, and because I'm an athletic therapist, I've given an outline of what maybe the athletic therapist would do in concussion management. Different professionals have different tools to contribute to concussion. Athletic therapists aren't the only profession that can contribute, for sure. There's many medical professionals that can, but really the preseason education is a big part. On-field assessment and first aid, sideline assessment, and then communication with the athletes, coaches, parents, and other medical professionals. And that can be part of that arranging for the referral for medical assessment. So we need to ensure this athlete does not drive home. Obviously, if they're over 16, they need to be taken home with a caregiver, or taken, this person that we're talking about in our scenario needs to be taken to the hospital for assessment of their facial injury and their concussion. And then they can't be left alone during any time, sort of in the next 24 hours. We don't necessarily wake people up at night, but they need to be reassessed after the injury several times to make sure things aren't getting worse. And then later on in the process, we can hopefully assist the person in returning to learn and returning to sport, and follow the directions of the medical assessment that and the physicians that they've seen along the way. So I'd like to turn it over to Dr. Ellis now, that since we've referred our athlete for medical assessment and they've been to the hospital, and we'll let Dr. Ellis take over from here.
Thanks, Jeff. So continuing on with the case here, the athlete ends up undergoing a medical assessment by a physician at a concussion program the day after her injury. On the clinical history, the patient reported that she did not lose consciousness at the time of the injury, but she did report a brief period of post-traumatic amnesia. She denied experiencing any acute neck pain or focal neurological deficits at the time of the injury. On the date of her initial assessment, her post-concussion symptom inventory score was 25. And on clinical interview, she continued to experience some persistent headaches localized to the back of her head and bitemporal regions, nausea, dizziness that she described as lightheadedness without vertigo, sensitivity to light and sound, fatigue, intermittent blurred vision in her right eye, and difficulty with memory and concentration. She also reported some neck pain, but denied any weakness or numbness in her extremities. She reported feeling more anxious than normal, but denied experiencing any panic attacks or thoughts of self-harm. On her past medical history, she does have a history of 2 previous concussions, as well as anxiety and depression. The last concussion that she had previous to this was managed by her primary care provider, and she recovered after approximately 2 months of symptoms. She was diagnosed with anxiety and depression approximately 2 years ago. Her medications include fluoxetine. She has no allergies. She denies smoking or using any alcohol or recreational drugs. She lives with her parents and a younger brother and does not play any other sports besides basketball. Obviously here, the physical exam is a lot more comprehensive than what's included in the SCAT-5. On her physical examination, she's alert and cooperative. Her speech is normal. Her cranial nerve exam is grossly unremarkable, including all aspects of her vision and ocular motor functioning. She does have some right periorbital swelling and bruising. Her motor and sensory exam and cerebellar testing is normal. She does have some postural instability identified on balance testing. She demonstrates full range of motion of her cervical spine with some paraspinal muscle tenderness, but no central spine tenderness. And looking at her ocular motor assessment, it's fairly normal. The physician reviewed the CT imaging of her head and facial bones to ensure there weren't any abnormalities that weren't identified, and decided that there weren't any new investigations that were indicated at this time. So following the medical assessment, this patient was diagnosed with an acute sport-related concussion and associated whiplash type injury and soft tissue facial contusion. The physician provided the patient post-injury education sheet, as well as education and guidance about how to make a gradual return to school and what sport-related activities she was cleared to participate in. She was provided a written medical clearance letter, and it was recommended that she follow up with her athletic therapist for supervision of her return to sport progression and consideration of initiating some manual treatment for her associated whiplash type injury. And she was also provided information regarding the need to seek emergency medical care in case of any visual deterioration. 1 week later, she was seen in follow-up and she reported significant improvement in her symptoms. Her inventory score was now 7. On interview, she reported some persistent neck stiffness that had been responding to treatment by the athletic therapist, as well as some persistent difficulty with memory and concentration. Her intermittent right eye blurred vision had resolved. She was feeling a little bit nervous about some upcoming exams, but denied any depressed mood or thoughts of self-harm. She returned to full days at school without any academic accommodations and was tolerating light aerobic exercise as well as sport-specific activities without any symptom exacerbation. Her physical examination showed some mild paraspinal muscle tenderness, but was otherwise normal. 4 days later, she comes back to the clinic and she indicated that she feels back to her neurological baseline or back to her normal self. There's no persistent neck stiffness. Her inventory score just indicated some mild anxiety. On clinical interview, she reported she was tolerating full-time school, completed her exams without difficulty, and under the supervision of her athletic therapist, had been tolerating low-risk basketball practice without any concussion symptoms. She had a complete physical examination that was normal, but given her history of 3 lifetime concussions, she did undergo a referral to a neuropsychologist to perform neuropsychological testing, the results of which demonstrated normal neurocognitive functioning with no concern regarding impairments secondary to concussion. The athlete was provided education and guidance regarding final steps of her return to sport strategy. She was provided a revised medical clearance letter. She was advised that there's presently no evidence-based guidelines to direct the return to sport decision-making in athletes with multiple concussions, but she was advised that given her history, she may be at an elevated risk of future concussion, which could lead to persistent symptoms or a change in her mental health. And she was advised to follow up with her primary care provider for ongoing management of her anxiety and depression. So carrying on where Jeff kind of left off, our national concussion guidelines do recommend that all athletes with a suspected concussion undergo urgent medical assessment by a medical doctor or nurse practitioner. In order to provide a comprehensive evaluation of athletes with acute head trauma, the medical assessment must identify, classify, and medically diagnose existing forms of traumatic brain injury, must rule out medical and neurological conditions that can present with concussion-like symptoms, and must be able to identify other diagnoses and medically diagnose them and manage them. The components of any medical assessment usually includes the clinical history, the physical examination, and the use of supplemental tests. The clinical history includes demographic information such as the age, sex, and gender of the patient, details about the event, where it happened, how it happened, when, immediate injury characteristics such as loss of consciousness, post-traumatic amnesia, seizures, what immediate symptoms the athlete experienced. It must review the results of previous assessments and diagnostic tests. It's important to assess past medical history, including a history of previous concussions, mental health disorders, other neurological and medical conditions, medications, allergies, history of substance abuse, social history, and to assess current symptoms, which is usually done through a clinical interview, but also assisted by the use of a symptom inventory. Again, the physical examination is much more comprehensive than the SCAT-5. This would include mental status, a head and neck exam, cranial nerve assessment, motor sensory reflexes, cerebellar, balance and gait testing. With appropriate expertise, the physician may consider more advanced ocular, motor, and vestibular testing. It's always important to assess the cervical spine to rule out any structural abnormalities, and it may include other tests depending on the clinical presentation of the patient. Supplemental testing is very rarely needed in the assessment of youth with acute concussions, but sometimes can include X-ray imaging of the cervical spine or the face or the extremities, or CT imaging or MRI imaging of the head or the cervical spine. In some cases, we will consider referring patients to a neuropsychologist for patients that have more atypical symptoms or brief symptoms. And other tests such as visual field testing, blood work, and EEG are fairly rarely used. Once the medical assessment has been completed, it's important that the physician communicate the medical assessment to the patient and their guardian, provide written and verbal return to school and sport education and guidance. It's important to provide a medical clearance letter or assessment letter so that the patient can advise their teachers and their coaches about what activities they're cleared to participate in. And it's important to arrange periodic medical follow-up, either virtually or in person. The principles of managing patients with acute concussion really is walking them through their return to school and return to sport strategies. The return to school strategy is just a stepwise outline whereby we help patients and athletes to expose themselves to increasing amounts of school while monitoring their symptoms. The return to sport strategy is similar in that, again, we're just trying to walk patients through each step where they're exposing themselves to increasing amount of physical activity to ensure that they're symptom-free before moving on to the next step. And then obviously providing the medical clearance to return to full contact activities such as full contact practice and return to sport gameplay. We're very lucky here in Manitoba that our government of Manitoba has taken a leadership role in trying to develop harmonized concussion protocols throughout our school divisions. So you can visit the government of Manitoba concussion landing page where there's an opportunity to access a template that can be used by all school divisions. And this allows the school divisions to develop concussion protocols that are harmonized with the Canadian guideline on concussion in sport and are harmonized with our sport-specific protocols throughout Manitoba. Again, under the leadership of Sport Manitoba, many of our provincial sport organizations have developed harmonized concussion protocols that utilize the principles and resources of the Canadian guideline on concussion in sport and are harmonized with our school board-based protocols. Basketball Manitoba's one of our all-stars when it comes to this. They were actually able to develop their own sport-specific return to basketball strategy, which physicians and athletic therapists and other sport therapists can use to help guide athletes return to basketball-related activities. Really, the end point of concussion care is ensuring that patients have made a clinical recovery, and we generally consider this in patients whose symptoms have resolved or they're back to their pre-injury clinical status in the setting of patients who have certain types of medical conditions that present with concussion-like symptoms like migraines or depression. We want to ensure that they're tolerating full-time school without any academic accommodations and are tolerating non-contact practice without any symptoms and are back to their pre-injury fitness level. We want to ensure they have a normal physical exam. And in some cases, some athletes will benefit from supplemental testing to help confirm either neurological or neurocognitive recovery. And return to sport clearance is really an individualized approach that needs to take into consideration the clinical factors such as injury characteristics and past medical history, as well as input from the patients and team sport therapists where available. Again, in the case that we described here, we did have the patient be seen by a neuropsychologist. Sport Manitoba took a leadership role back in 2018 to provide some recommendations regarding the use of concussion baseline testing in youth athletes. That position statement essentially indicates that preseason and post-injury testing should only be performed by a neuropsychologist and that preseason baseline testing is not recommended for youth athletes in Manitoba. So the role of physicians in concussion management, essentially the doctor's role is to conduct a medical assessment of athletes with acute head and spine trauma to ensure that the athletes receive the correct medical diagnoses, to oversee medical management of the athletes and provide medical clearance to return to sport activities. It's important that physicians work within their scope of practice and work closely with other healthcare professionals with expertise in traumatic brain injury to ensure optimal care of their athletes. And throughout working with athletes, it's always important and optimal if a physician has the opportunity to work alongside an athletic therapist or team physiotherapist to help oversee that return to sport progression. For additional information on interdisciplinary concussion care in adults, please feel free to visit the Manitoba Adult Concussion Network website. And for more information regarding the sport-specific protocols or sport-related concussion in Manitoba, please feel free to visit the Sport Manitoba website. Thanks so much for having me, and we're going to move forward to the panel discussion.
Excellent. Thank you very much to both Jeff and Dr. Ellis. And in addition to these two folks, we also have Dr. Patrick Fredette joining us and Leslie Ritchie. I see you there too. And Jeff, please help me. Am I missing anyone else that has joined us for part of the panel discussion tonight? I think I've covered
I
it.
don't think so.
Excellent. Okay, so we also would like to invite Carter to join in as well. If there are any questions for any of these folks, please feel free to add that to the chat, or we're a small enough group. If you'd like to come off of mute, you are welcome to do that as well. And I also know that Josh and Deborah have a few questions to get us started. So I'll open it up the floor here.